A 24-year-old female with ulcerative colitis had a subtotal colectomy and ileostomy performed as an emergency 6 months ago and come to your clinic asking what happens next. What do you tell her? So I will tell her there are three options at the minute. So one is that the surgical option is no further surgery, would need annual surveillance of the remnant rectum, and may develop some pouchitis which can be controlled by the topical therapy. But second option is ileorectal anastomosis, but it will need annual surveillance. And third option is restorative proctocolectomy and ileoanal pouch anastomosis, and which is very common in UK. And the last is proctocolectomy, completion of proctocolectomy, and permanent ileostomy, no surveillance needed. So actually four options. So when offering pouch surgery, what other aspect do you need to consider? Rule out the first good sphincter function, exclude the Crohn disease, and should not be performed in a patient with anorectal lesions like active lesions like sepsis, ulceration, or anal lesions. Exclude the sclerosing cholangitis because there is a high incidence of pouchitis. And fecundity, decrease in female fertility after pouch surgery. So either delay the surgery or accept the risk of reduced fertility, which can be generally overcome with in vitro fertilization technique. When consenting the patient for pouch surgery, what complication do you mention? So first, your bowel function will never be normal. Pouch failure about 10%, and this pouch failure is due to the pelvic sepsis, poor function, and bowel inflammation. And third is anastomotic leak 5%, small bowel stricture or fistulation 10%, pelvic sepsis 15%, lead to the pouch excision and poor function of fistula if late presentation. So pelvic sepsis is the main cause for the pouch failure. Then is the pouchitis 30%. So pouchitis increase with the passage years. In first 5 years it's 9% chances, in 10 years 12%, in 20 years 18% risks of pouch failure due to. And then reduced fertility in women and sexual dysfunction. And but their overall general sexual satisfaction is improved because of the general improvement in the health. And then the stool frequency 6 per daylight and 2 overnight nocturnal. Incontinence to flutters or stool 5% during the day, 10% during the night. Staining and swelling of the enterourethra with the need for the pads. Oral mortality 4% morbidity 16%, 13%, reoperation 16%, morbidity 30%, reoperation 16%. Need for defunctioning loop ileostomy complications such as a peristomal hernia, stenosis, and high output stoma. So what is normal pouch function? 6 to 8 times stool per day and 1 to 2 times over the night. Loose stool like a porridge, ability to defer the defecation, no fecal leakage in the daytime, may occur at night. What is a pouch failure? Failure is defined as the need to remove the pouch and establish a permanent ileostomy. Need to remove the pouch and establish permanent ileostomy. 10% pouches fail over a 10-year period and will result in a permanent stoma. So 1/3 patients are happy with the pouch, 1/3 patients have problem but they manage, and 1/3 patients have problematic pouch. So 5, 10, and 20-year cumulative risk of 9%, 12%, and 18% respectively. First 5 years, 9% chance of pouch failure. Next 10 years, 12% chance of pouch failure. Next 20 years, 18% of the pouch failure. And the learning curve in the pouch surgery related to the pouch failure. And what is pouchitis and what's its cause? So pouchitis is inflammatory response to the changes within the pouch. Etiology is unknown, thought to be triggered by changes in the intraluminal bacteria within the pouch. 20 to 50% will suffer pouchitis at some point, and characterized by a still frequency, urgency, liquid stool, abdominal pain, and fever, more common in smokers. And diagnosis based on the histology and the finding at the endoscopy. It's not only clinical, so histology may be needed for the confirmation. Follow the Sindmark algorithm. So Cipro and Metro for 14 days and rule out the cytomegalovirus and C. diff. Then repeat the antibiotics for 28 days, and 28 days alternative antibiotics like Comox and clarithromycin. Consider maintenance therapy, and if maintenance therapy, consider probiotics VSL3. Thank you.